everyone. Thanks for joining us. Today we're going to be talking about care of the incarcerated patient from bedside to abolition. We have a great set of speakers here today coming to you from Los Angeles and New York, but we're hoping to share some of our experiences and some of our knowledge that we think will definitely improve your care for individuals who are in custody, and also really work to transform um, you know, incarceration in this country as we know it. So objectives today, we're going to start out with talking about policing and incarceration as a structural determinant of health. And by that, I mean understanding the processes that have led us to our current moment of heavy incarceration, policing, and kind of racist police practices that have really come to light in the current moment. We're going to talk about how incarceration is a barrier to health and really kind of a social determinant of health in and of itself. We're going to go on to pragmatic solidarity, and by that I mean what can we do in emergency department settings and in hospitals to really promote the care for people who are incarcerated. And then we're going to move beyond that. In addition to the work that we do in hospitals with our patients, how do we engage in movements and broader organizing to undo some of the structures that I'm going to highlight here at the outset. I'm going to let all the speakers introduce themselves before they begin their section. My name's Shamsher Samra. I'm based in LA. I work in the emergency department at Harbor UCLA and also with the LA County jail system. So I just wanted to step way back, and people may be familiar with some of these statistics. The United States is infamous in our rates of incarceration. 5% of the world's population, 25% of the incarcerated population. Kind of leaps and bounds beyond other countries, so about 6 times the rates of incarceration compared to Canada. And what we know is that in the United States, we are not incarcerating a random swap of our society. We're disproportionately incarcerating Black, Brown, Indigenous communities at really remarkable, really kind of unfortunate rates. And beyond the racist element of our current, the carceral system, we have a disproportionate incarceration of people who are poor. And you see that this is the case in both men and in women, that the vast majority of people who are incarcerated are low income or were low income prior to their arrest. I wanted to show this slide, which basically trends rates of incarceration over the last almost century now. And the thing I want people to draw from this is that the moment that we're in right now is something that hasn't always been this way. It's something that's been created by individual structures of power. And as a result of that, it's something that can be undone as well, particularly in this moment where, we're having a lot of recognition of police violence, calls for Black Lives Matter and defund the police, thinking about how we as healthcare providers relate to undoing this process. And I also wanted to kind of unpack what's in these charts here. So you can see back in the 60s and 70s, we start to see this uptick in incarceration. And then we get this huge peak, which people refer to as the prison industrial complex, mass incarceration. But some of the things that go into it are, we have kind of deinstitutionalization of mental health hospitals. So severely mentally ill people who would stay in those hospitals for long periods of time. The plan was, let's get them out of these facilities and get them into community-based systems of care. The facilities were shut down. The investments in the community-based systems of care never happened. We had deindustrialization going into the 80s, where we lost jobs due to economic globalization, global capital. And instead of creating new job opportunities and investing in communities, we put people in jails instead. And you have the decade of austerity measures and reductions in public spending. Same time in the 80s, we have the war on drugs, and we really ramp up policing of poor Black and Brown communities in the United States. And, people might ask, how does this relate to emergency medicine? And the reality is, while we're drawing back funding for mental health institutions and jobs and employment and things like these, it's also healthcare that's getting scaled back. In Los Angeles, where this map is from, we had a plan to expand primary care, preventative care in communities, and that was scaled back. Instead, the decision was made to be cheaper to just have people access emergency services. So what you have is a current system where people with mental health crises, with substance use issues, either end up in emergency departments or they end up in jails or custody settings, and we just don't have the infrastructure in place to do what people actually need to get better and get healthy as a result. This chart is from LA, but it's similar in other places across the country. This is from the $1 Million Hoods Project. It just shows where money is being spent on incarceration. And again, it's not random. It's particularly Black and brown and poor communities, South LA, and kind of the desert areas. And this is, this segregation happens in other cities. And the same things kind of play into it. We have job loss. We had loss of, wartime jobs in aerospace industries. And then we had redlining and racist policies for home loans that limited people's abilities to leave some of these underserved areas. And instead of investing in schools and healthcare and things like that, we invested in heavy policing. And you can see how these communities are policed and by proxy incarcerated at higher rates. And as a result, these are the communities that are ending up in our emergency departments in custody. And with that, I'm going to hand it over to Dennis.
So I think on this background, we're really talking about how we as providers can. So on this background, this is really talking about how we as providers can work to address some of these structural, social, and racist barriers. And my name is Dennis Hsieh. I'm one of the faculty at Harvard-UCLA and the Director for Social Medicine and Community Health. So I'd like to bring forth the idea of pragmatic solidarity, which basically means not just having compassion and empathizing, but really doing something about the compassion that you're feeling and the empathy and really addressing the issues at hand. So I think our speakers later will talk about this, but I really wanted to highlight a little bit of the disparities that occur not just from a social perspective and a structural perspective, but from a health perspective, and some of the work that we can begin to do to address these. So from the LA County budget, I think this is similar to many budgets across the nation as we hear about the movements that have happened recently in the wake of the shootings of many of our unarmed citizens. This shows that LA County, like many other places, spends a ton of money on healthcare, but even more on policing. And if you look at all of this together, it really shows where our priorities are in terms of addressing other issues of why people end up in jail or prison, such as housing, workforce development, and other supportive programs. And for individuals coming to jail and prisons, there's a ton of disparity in terms of all sorts of conditions. It's not just communities of color, but the disparities that we see in our communities of color are reflected here in terms of asthma, HIV, other chronic conditions. For example, across the United States, the general US population has a much lower prevalence of HIV than those who are incarcerated. Similar for chronic hepatitis C and other many conditions such as serious mental illness, substance use disorder, co-occurring mental health and substance use disorder, individuals experiencing homelessness, chronic medical conditions or multiple chronic conditions, as well as a history of physical, mental, or sexual trauma or abuse. And Los Angeles County, unfortunately, has a distinction of being one of the largest jails in the United States, and therefore, given all the disparities we talked about, also the largest mental health institution in the United States. And across the US, as individuals were de-institutionalized out of mental health hospitals, they subsequently ended up incarcerated. So we ended up moving from a institutionalizing framework in one setting to another setting where the focus is not really health and is custody. And I think as ED providers, we have to remember this as we take care of individuals who are going into custody as well as individuals who are in custody who come to us for treatment for acute conditions, as well as those who have left custody and are showing up in the emergency department asking for help with medications, connecting to housing, in connection to care. And I think the reentry piece is often probably the largest population that we see, or one of the largest populations that we see. And there's a huge risk of death during this time. This figure from the New England Journal shows actually a 12.7 risk of death just due to homicide, suicide, overdose, cardiac disease, and other factors. And why is this? I think if we look at the system of care or lack thereof in the jails and the prisons across the U.S., this helps us get a better understanding why reentry is such a vulnerable time. So in terms of correctional health and what's actually provided in custody, the Eighth Amendment guarantees freedom from cruel and unusual punishment. This lawsuit in 1976 established that access to care is one of those rights that individuals in custody have that otherwise they would be facing cruel and unusual punishment. However, at the same time, there's a federal inmate exclusion policy that prevents any inmate who is in custody from having Medicaid or other healthcare access. And I think if we look at individuals who are in custody, we see a large number of people who used to have Medicaid or Medi-Cal in LA County, and this is similar across the United States, but an even larger number who are uninsured, once again reflecting the vulnerability of this population. And given in custody, we're working in a custody framework, there's not much thought given to this. And I think Harbor, where I work, compared to Twin Towers, which is one of our big jails in LA, it's very much two different frames of reference. And I think when you first look at this and examine the differences, you might have this reaction. Why are people doing things that don't make sense? It can make you angry or even your head want to explode. But I think to really understand why this is, you really have to go deeper. You have to get a different understanding of how corrections or correctional health works and why this makes it even more important that you, as a frontline emergency department provider, advocates for these individuals when you see them. So in the LA County system, this is the technology that is currently being used. It is a completely different system and operates in a custody framework, meaning the sheriffs, not the healthcare providers, control everything. And how does this affect patients or individuals in custody? Well, normally when someone's in the hospital, you as the provider has the ability to make the decision of when someone's admitted or discharged. In custody, that decision falls to the law enforcement agency. So it doesn't matter if someone's diabetes is out of control, they're decompensated from a mental health perspective, or they just had a stroke. If the sheriffs and the courts have decided that time is up and this individual does not need to be in custody, they are sent out of jail back into the community without much thought as to what happens to them, where they're going to get their medications, where they're going to get their health care, where they're going to be housed. And I think in terms of, from a healthcare perspective, some of the basic work that has started being done in places like Los Angeles County is recognizing that this is a problem. You know, as emergency physicians, I'm sure we have all seen individuals coming to our emergency departments after leaving jail or prison, asking for oxygen, asking for medication-assisted treatment, asking for their insulin, because no one on the custody side gave any thought of what to do, what they had to do. They just wanted them out of custody because their time was up. And so in LA, we started working on things such as ensuring individuals have access to insurance and are insured by the time they leave, and that they leave with a 30-day supply of essential medications. And I think this is something you as an ED provider, if you're tired of seeing individuals show up in your ED immediately after discharge or soon thereafter discharge, sick, and asking for help, these are some of the systems things that you can help advocate for. Furthermore, there are a lot of other needs and obviously a lot of opportunity for partnership with community partners. And I'm going to let the rest of the team address some of these more specific issues as we move forward.
Hi, my name is Todd Schneberk. I'm an emergency physician at LA County USC, which means I work in the jail ED, which is part of our facility that is the receiving facility for emergency health visits from Twin Towers, which Dennis covered in the last section. So I'm going to be talking to you a little bit about the idea of dual loyalty, and specifically at the bedside, some of the ethical concerns that you should be aware of as an emergency physician, as somebody treating patients that are in custody, whether that custody is detention, both immigration and juvenile, versus prison, versus what we see, which is jail. Importantly, these patients are, as Dennis alluded to, under the control of the carceral system. And the carceral officers, especially in LA County, are the ones who are controlling whether they have access to healthcare, whether they can go to the healthcare facility. And they do not, in the same sense that a person in the civilian sector would be able to seek care. And so it's important as healthcare providers that we consider that, as a provider in this jail ED, as we call it. I've encountered certain situations like patients coming in with deputies that are requesting a cavity search or requesting that this person be examined and medically cleared against their will. And this is emblematic of this concept of dual loyalty. Dual loyalty specifically is the ethical dilemma commonly encountered by our healthcare professionals, where there's a clinical role conflict between professional duty to a patient and obligations either expressed, explicit, or implicit to the interest of a third party, such as an employer, insurer, or the state. Specifically in this situation, it is the sheriffs. And one of these ideas and concepts to understand is that working in a jail ED, you are on the side of the cuffs and on the side of the bed from the patient, and you are on the same side as the sheriffs. And the way that is kind of internalized often can lead to hegemonization, something documented more thoroughly in anthropology literature. But it is important for us to know that we are not on the side of the sheriffs, or we are not on the side of whoever the arresting officers are. First and foremost, our duty is to the patient, and our duty is to the health of the patient. And things like, egregious things like a cavity search is not within our purview, and is not something we should be engaging in if the patient does not actively request it. And brings us to the point that, we have laws and protections for patients that we know of as a result, of the rest of our practice, in terms of there is still mandatory reporting for juveniles and elder abuse. And these patients still are entitled to the same rights. They still get to refuse care if they want. They can say, hey, I don't want to be examined. I don't want this medical procedure. I don't want this, I don't want to be here in this ED. I want to leave. And we are not required to do anything at the behest of sheriffs or law enforcement, unless we think it is in line with what is best interest of the patients, and it is what the patient would want or does want. So that's an important thing to distinguish and understand before going into these settings. And dual loyalty and these kind of patient protections is often something that is not sufficiently explained or trained of healthcare professionals that are providing care in prison settings, and something that's been documented in both the US as well as other countries like England, where we have the tendency to be hegemonized by the law enforcement personnel. And I'm going to let Frank talk a little bit more about how
Hey, how's it going? So my name is Frank Coughlin. I'm a ER attending in upstate New York and Western Massachusetts, and happy to be here with y'all. And yeah, I just want to build on what's already been talked about in terms of, how do we go from this kind of theoretical and statistical analysis of kind of mass incarceration and structural violence around policing and police efforts, and how does that kind of affect our care at the bedside? And I think one thing that has been kind of talked about is kind of that in this current era with the COVID pandemic clearly ravaging detention facilities across the country, as well as prison facilities, clearly in violation of the 8th Amendment of cruel and unusual punishment, as well as just clear human rights violations. And in the setting of the recent Black Lives Matter uprisings, I think we as a profession are being called to reevaluate our relationship to incarcerated populations, and specifically to how we deal with and defer to police authority and detention authority. And so kind of to build on this idea of mandatory reporting that is very commonplace for us to know in emergency medicine, and as anyone who interacts on a professional level with patients, is that we have a mandatory role in reporting suspected abuse for children, for the elderly, be it physical, mental, and probably in the case of elderly, economic abuse. And many groups have been advocating for a long time that we also view incarcerated populations and detained populations as a vulnerable population. And that thereby we also have a duty to be mandatory reporters for suspected cases of abuse. And this is secondary to their inability to access care, limited freedom of movement, and also rethinking the police force as an example, as a bad example of structural racism and structural violence. And this is a term that has often been thrown around, especially in recent times, with kind of a lot of tension on institutional racism, as well as institutional patriarchy from the Me Too movement. That a definition of structural violence is one way of describing social arrangements that put individuals and populations in harm's way. Arrangements are structural because they are embedded in political and economic organization of our social world. They are violent because they cause injury to people, typically not those responsible for perpetuating such inequalities. And with few exceptions, clinicians are not trained to understand such social forces, nor are we trained to alter them. Yet it has long been clear that many medical and public health interventions will fail if we are unable to understand the social determinants of disease. And I think, COVID is a horrific example of structural violence, where as data is becoming released from the CDC and from the Departments of Public Health, that COVID is disproportionately affecting Black and brown populations, and that a recent study showing, depending on what hospital you went to in New York City, it radically influenced your mortality and morbidity up to 10 times, just based on whether or not you went to a public versus a private health institution. So these are clear examples that there's something going on in our structures that is causing ill harm towards populations. And, this is something that is also built on around this idea of structural racism, that there are many studies, and I encourage people to look at some of the resources in the presentation about structural racism within medicine. And as is becoming more mainstream now, looking at police as a perfect example of structural racism. As was said before, the mass incarceration is not just a random distribution of people who are put in prison, but clearly overwhelmed by Black and brown populations who are being targeted by incarceration. And I would also advocate that as medical providers, as clinicians, as people who are on the front lines of working with the society, that we need to reevaluate our understanding of how police are. And I think something I've heard a lot in doing work in institutions is that, we are on the side of police and, towards the public good. And as was just brought up around, this hegemonization of sheriffs, that we are not actually on the side of police, that police have a goal of societal control, and medicine and public health have a goal of individual and community health. And so we need to start creating systems that address this difference in beliefs and also look to prevent abuses of police. And there are a few ways that we have started talking about doing this. One is protecting against systemic obstacles, as well as implicit and explicit biases. So, some systemic examples are the logistical difficulties of transferring patients who are incarcerated from prisons and jails and detention centers to medical facilities, the lack of freedom of access that most of us experience, in the quote unquote free world. The use of for-profit care centers within prisons, clearly creating a conflict of interest between patient care and profits. A lack of training of providers, as was also previously mentioned, that most providers don't even consider that incarcerated patients and populations have any rights. The fact that everyone who works in an ER knows it's extremely busy, it's hard to do research, and we often feel overwhelmed and under-resourced to address these structural issues. And then I would also add in there the structural racism that exists in medicine, that there is an implicit power hierarchy of the provider and the patient who we give information and treatment to, and oftentimes the patient does not have much say. And this is exacerbated when there's implicit racial bias. And then we have these implicit and explicit biases that, I would argue that in medicine, the majority of providers are mostly white and mostly come from middle, upper class backgrounds. And so most of our interactions with police have probably been fine, except for, maybe getting arrested for illegal drinking in high school. So they're usually positive interactions. We have an ingrained deference to authority that is kind of trained in our way of being trained as providers. Police often exert an unfounded authority in EDs, that they view the ED as their kind of jurisdictional purview, which is false. And then there's a kind of a cultural belief that people who are jailed and people who are in prison kind of quote unquote deserved whatever treatment they got. So there's a lot of obstacles to providing good care in compliance with the 8th Amendment that was brought up in the beginning of the presentation. One thing that we started doing at Bellevue Hospital in New York City was to start reusing protocolized treatments and protocolized standards to help address some of these biases. And, in emergency medicine, we're very comfortable with protocols. We have trauma protocols, sepsis protocols, ACLS protocols. And the idea is that these are not dictates, but instead to help guide clinicians and also allow flexibility for however the situation can be. It also provides support, both a mental support as well as an administrative support in high tense, high stress situations. And so I'm just going to kind of review some protocols that were used at Bellevue. Some protocols that were used at Bellevue, and some of these are site specific, and so each institution will have to have their own thing. But at Bellevue specifically in the ED, we had a relationship with NYPD to do quote unquote medical clearance exams, as well as a relationship with Department of Corrections through Rikers Jail specifically to admit patients who needed higher level of care. So the first part is Article 1, and this provided guidance for medical decision-making regarding follow-up and specifically around admissions. And essentially, kind of as was said before, thinking of being incarcerated and being detained as a poor determinant of health, and using that as a reason to actually lower the barrier that needed for admissions. Thinking of that specific chronic illnesses such as heart failure, cellulitis, withdrawals, etc., that just because somebody is detained would actually maybe increase their ability to be admitted, because their potential decompensation is more likely and would be worse off because of their being detained. It also would put in there that if a provider had concern for potential abuse from either the NYPD or the Department of Corrections, that this would also be on its own a reason to admit somebody to the hospital for further care to be brought up. Article 2 addressed ensuring appropriate follow-up and care in detention facilities. And this is kind of a little bit similar to what had been talked about before, but oftentimes what we would see is that people would be brought in for quote unquote medical clearance and then brought back to the jails, the tombs is what they call them in New York City, or the prison to Rikers, and that there was an attempt to shift the burden of providing adequate medical care from the prisons and detention centers to the ED, which is something that we wanted to fight against. And so we really pushed on making sure that people had adequate follow-up and very clear instructions on when their decompensation would require a further transfer to a higher level of care, and continuing to put the burden of care back onto detention centers and jails, that it is their constitutional responsibility to provide adequate health care. And also to make sure that discharge paperwork and discharge instructions were clearly explained. And this is maybe anecdotal to what we experienced in Bellevue, but most detainees and incarcerated folks were not able to really know that they were being discharged, were not able to hold any paperwork, and often were not able to, the provider was limited in their ability to explain discharge instructions. And so being very explicit and careful in how we explain discharge instructions, increasing this transfer of medical care to the providers at the jail or at the NYPD holding centers, and in a way that provided privacy to patients. So using signed, secured envelopes that officers could not rifle through, could not look through, and go from there. We also addressed the idea of medication. So kind of further pushing providers to feel okay and supported in discharging incarcerated folks and detained folks with medications such as albuterol inhalers, even pain medications, because of limitations in a lot of detainee facilities. They couldn't provide adequate pain medication specifically. And lastly, we also included information on the Civilian Review Board, which is for NYPD interactions, that was given to all folks who came to the ER, that if they had any complaints about possible abuse by the NYPD, they had the information at hand in their discharge paperwork from the emergency room. And lastly, the third article was dealing with responsibility of providers when interacting with officers. And the primary purpose was to protect patient privacy. As I'm sure we've all experienced, most of the time officers, when they bring patients in, they stand in the room. It's extremely difficult to get a good exam and a good history, and especially in sensitive situations such as recent cocaine use and having chest pain, patients are understandably hesitant to provide adequate information because of fear of reprisal. Also, one thing that providers don't often know is that anything that is said in the presence of law enforcement officials can be used in a court of law, which has been seen many times. So mandating that providers have to ask all officers to leave the room, and if needed for safety concerns, they can maintain line of sight observation, but that has to be far enough away that they can't overhear all conversations. Also, the regulation of restraints, that providers are able to ask for restraints to be removed, that limiting that restraints can be put on at one point, and cannot have multiple points of restraints, cannot have long-term painful restraints, and that these need to be addressed by officers under the care of providers. And lastly, kind of this other idea that had just been brought up of it kind of making it more clear to providers of when they are mandated to provide information to NYPD, and that unless they have a signed warrant, they are actually not allowed to provide any information to NYPD or Department of Corrections. One thing that we would like to add, and this is something that Todd will talk about, is making it easier to report cases of abuse. And this is an area of improvement that we had been working on. All right, so I'll give it back to Todd here.
So something we want to just highlight as a goal of specifically documentation and creating accountability within the medical record and within medical care for the justice and health justice of these patients is something that was employed at Rikers under the leadership of Dr. Homer Venters, who was head of Rikers at the time, and trying to, the main portion of this initiative or the thrust behind this is to try to take what we know from, kind of forensic evaluation and some of the work he had done prior with Physicians for Human Rights and some of us who work in asylum and other kind of forensic documentation clinics, taking that and trying to input it into the medical record so that some of this documentation that substantiates claims and validates injuries and stories of inmates can be readily available for different uses. Specifically, this is, this paper in Health and Human Rights outlined this kind of individual patient injury encounters and specifically focusing on how it happened, the circumstances behind it, what injuries were sustained, and then categorizing this in a way that could be easily abstracted. And one of the things they did in aggregate reporting is they showed, as you can see here in this bar graph, that solitary confinement of mentally ill patients was resulting in large amounts of injuries to those patients, to those inmates. And because it was such a substantial outlier from the other settings, they were able to then take that back as a policy to jail administration and say, wait, why are we doing this? Why are we putting mentally ill people in solitary confinement? It just results in injuries. And can we find a way to not perform this practice? And if so, that may result in less injuries, which ultimately it did. And so trying to think about how some of these principles of patient-centered documentation and patient-centered forensic validation of what has happened, and whether that be abuse or whether that be injuries due to other factors in prison, can be documented, substantiated, and then perpetrators can be held accountable. And I'll stop with that.
Okay, hi everyone. I'm Jeremy. I'm presenting on behalf of both me and Mark Anthony Clayton Johnson, who cannot join us today. So for this last portion of the presentation, we ask and venture some answers to the question, why abolition? Why bedside to abolition and not, for example, to cell block or to the street or to the courtroom or to the policy table or to the budget spreadsheet? The vision of abolition does, in fact, include all those places, but it will also take us beyond those places too. So abolition is the only practical alternative. This statement may appear a contradiction in terms. Prison abolition is often dismissed exactly for its impractical demands and its utopian vision. Critics are not entirely wrong that abolition is utopian in the sense that it stems from a philosophical rejection of the reliance on police and prisons to be used as, Ruth Wilson Gilmore puts it, catch-all solutions to social problems. But prison abolition is also practical in the sense that as a vision, it guides strategies and tactics for change. And we begin with this phrase, that it is the only alternative to center the experience for those at the margins, those communities most affected, who have endured reform after reform to the criminal justice system only to continue to experience abandonment and violence by that same system. But for those communities, abolition is indeed the only practical alternative. So what do we mean by abolition? You go next slide. Abolition is an absence, but it's also a presence. And what we mean by this is that it's the absence of jails and prisons and the systems that lead to them, police, probation, parole, and incarceration. And so the pursuit is focused in producing that absence. But abolition as a framework also tells us to think about all the kinds of organizing and institution building that are remaking society and would need to remake society so that it can never have prisons. As abolition theorists guide us, abolition is not a blueprint, but a vision. And as a vision, it gives us a practical program, but for radical change. Next slide. So what does abolition tell us? What are the kinds of insights that we can gain from using an abolitionist framework? First, abolition, with its insistence on what theorists call non-reformist reforms, which are those reforms that reduce the size and scope of institutions dedicated to surveillance and punishment, that in other words, reduce our reliance on using jails and prisons as catch-all solutions to social problems. That framework then offers us a strategy, and it also offers a lesson about how oftentimes the very reforms that reforms to efforts to systems of punishment can in fact have the effect of strengthening and expanding their overall power. Thinking historically, prisons themselves were once the reform. So it can't just be reform, and abolition is as a framework tells us we need to look beyond just things that we think as reforms to an existing system. The second insight is that the massive criminal justice infrastructure that we now have is not part of is not a natural part of the social landscape. As Shamsher opened, thinking historically, our current situation is historically contingent. It was not always this way. It was not inevitable that jails and prisons would fill our urban and our rural landscapes. It's not inevitable that there's over 70 million people that now have criminal records. Instead, actually, it's a result of changes to racial capitalism, the context we live in the United States. So we can go to the next slide. So then thinking, okay, why abolition for us as medical providers, us in the health professions? So by abolition, moving beyond just talking about the criminal justice system and putting those institutions into their wider context, abolition focuses attention on building alternative institutions that would be needed in a future without police and prisons. It is here where health professionals like us have such a central role to play. Health professionals can and should be part of building what needs to be present for police and prisons to be absent. Next slide. So this framework also does something really critical for us in thinking about our organizing and thinking about our political strategies, because it tells us we need to move away from thinking about the innocence or guilt of particular individuals, and away also sometimes from thinking only in terms of rights and responsibilities, and towards thinking about systems of harm and how those systems of harm came to be and what it would take to undo or reduce the size of those systems of harm, and in their place build systems of healing. So rather than fall into the trap, as is often the case, and we've seen it historically, of just trying to find those people that are most relatively innocent, our attention by this framework should instead be on what the kinds of laws and processes that lead to so many people being criminalized, put into this category of innocent or guilty. And we should, away from that, we should think about how we can produce alternative systems. So this kind of abstract theorizing does actually have immediate and urgent relevance to us as health professionals. And to kind of make that clear, I want to now lead us into an example from Los Angeles in the past 5 years. So next slide. And Shamsher, could you play the first video, which is the launch of the Justice LA campaign back in 2017?
Today we're preparing for our action that we haven't, to let them know that we still not for their new jail plan. It's important that we be strategic and make sure that our message and get also one that doesn't be blocked off when we try to get there, but also so that people feel safe and know what's going on, so that just in case something does happen, it doesn't get chaotic.
We're out here today delivering 100 beds to the county Board of Supervisors, specifically to talk about their jail expansion plan, $3.5 billion to go into caging our loved ones.
This county is trying to invest in over 3,000 jail beds. And what we're saying is that that money could be used elsewhere.
LA County is the biggest jail in the world, the biggest jail system, and we do not need more jails. We need to deal with these symptoms of issues. We need to stop criminalizing poverty. We need to stop criminalizing mental illness.
So in that last video, which was to launch the campaign against LA County's plan to build a new jail in 2017, the Justice LA Coalition described how Los Angeles had planned to build a new jail on a system that already was the largest in the world. Those plans evolved over time in terms of what exactly that jail would look like, but as of 2015, 2016, the way that jail plan was being articulated was through the language and lens of health. That is, the county was saying for the health needs of the future communities that will be incarcerated, the future incarcerated population, will need to have a mental health jail or a treatment jail, a jail that is suited towards the health needs of incarcerated people. In the next slide, previous slide, what Justice LA, how they intervened, and the group Frontline Wellness Network, which was founded by my co-presenter, who's not here, Mark Anthony Clayton Johnson, we intervened in that process, in that policy conversation to say, wait a minute, rather than build a jail that meets the health needs of its future population, Los Angeles should not build a jail because jails can never meet the health needs of incarcerated people in their wider communities. Health professionals, while they had been a part of an external consultant report that had outlined what a mental health jail could look like, had up to that point been fairly silent. So as I describe in the next slide, as health professionals, it was critical to join into that conversation and make our voices known and make our opinions known, and answer the question, what services do our patients need instead of arrest and incarceration? The Frontline Wellness Network put together a far-ranging group, medical students, nurses, physicians assistants, psychiatrists, emergency doctors, epidemiologists, social workers, to answer this question, and we made our voices heard through letters, petitions, public comments. We organized demonstrations, and we met with all 5 supervisors' offices. Then in 2019, with the health professionals, with us as part of the conversation, making it clear what we see as needed and absent in Los Angeles, the LA County Board of Supervisors came to a different decision about what they would decide to do. And so this next video describes what happened then 2 years later in August 2019.
This fight is about our siblings. It's about our fathers, our sisters, our wives, our girlfriends, our boyfriends.
Incarceration and state violence never did and never will heal anything. The county that has for so long been the leader in all of these dubious things can now potentially shift and be the leader in a vision that's about care, that's about community.
We don't belong in cages. We belong in our society, supported to become who we are destined to be.
The nation is looking and they will follow what happens here. So it's important. We have a huge responsibility.
Yes, we can. Sí se puede.
Incarceration is new Jim Crow, and it's about time that we end that and we look towards community care.
I think we need to reallocate some of the funds back to our communities so our kids can be back involved in sports, after-school program. These programs is not there no more.
The sheriff purports to support public safety when in fact they are the ones that are harming our communities. If we want public safety, we need to remove them from the equation.
We have had a paradigm shift on this Board of Supervisors. It became clear to us that we could not create this model within the confines of this contract.
Incarceration is itself an experiment, and it's an experiment that has failed.
Supervisor Solis, aye. Supervisor Ridley Thomas?
Aye.
Supervisor Ridley Thomas, aye. Supervisor Kill? Aye. Supervisor Kill, aye. Supervisor Barker?
No.
Supervisor Barker, no. Supervisor Hahn?
Aye.
Supervisor Hahn, aye. Motion carries 4-3.
What just happened is kind of still settling in.
Absolutely.
This has been steadily chipped away by all of you. We've witnessed today a huge shift in terms of how we view public safety, how we view our communities, and how they're going to get funded.
This is a moment where we're celebrating and we're also continuing to fight, right? Because this is not the only jail project.
We have to make sure that whatever is implemented, how we move forward, is still in the model of abolition.
But we're soaking up this victory that has been long and hard fought.
Being a part of a movement and a campaign that actually stopped the construction of more cages is one of the most fulfilling and overwhelming experiences that I could.
If Los Angeles can stop building jails and start investing into communities, so then the rest of the country can. The people of Los Angeles rose up, fought back, and we won.
So as that video movingly demonstrates, Justice LA helped move the County Board of Supervisors from their plans to build a new jail, to already the largest jail system in the world, to abandoning that plan, and then more recently, as of just last month, deciding that they were going to close their largest jail facility without any plans or plans to add new jail beds to the system. In this transformation, health professionals through the Frontline Wellness Network have played a critical role. And so, as we conclude this session from Bedside to Abolition, this model hopefully demonstrates the many fronts on which abolition as a framework and health professionals joining in, using that framework can guide our action and can lead to the kinds of structural transformations our patients so desperately need. Thanks to all that listened and joined us today.